We were yesterday learning about anti-tubercular drugs. We learned about the first line of drugs: isoniazid, rifampicin, pyrazinamide, ethambutol. Today we'll learn about streptomycin. So, coming back to streptomycin, it belongs to the category of aminoglycosides. Belongs to the category of aminoglycosides. It is a tuberculocidal drug, the first drug to be used, and it is an injectable drug. Already we have learned the mechanism of action of aminoglycosides. Streptomycin, belonging to the same group, has the same mechanism of action, that is protein synthesis inhibitor. It is a cidal drug. What is the mechanism of resistance? Mechanism of resistance is by alteration of the 16S ribosomal RNA, that is alters the ribosomal binding site. What are the adverse effects of streptomycin? It's an injectable drug, so on the site we can have local tenderness. Other than that, it can cause ototoxicity, nephrotoxicity, vertigo, hearing loss, neuromuscular blockade. This drug is used as a first line of supplemental drug. It is used for a maximum of 2 to 3 months. The newer drug which has been added to the RNTCP is a program, revised National Tuberculosis Control Program. Now this is called NTEP. Bedaquiline is a newer drug. It acts by inhibiting the mycobacterial ATP synthase. It is a bactericidal drug. It is not used as a first line of drugs. We use it predominantly for multi-drug resistant tuberculosis. The second line of drugs like ethionamide, proethionamide, cycloserine, terazotin, varamino-salicylic acid, rifabutin, thiacetazone, and also fluoroquinolones, along with injectable drugs. We learn the first line of drugs along with what are the regimes under RNTCP and how these drugs are given. So we already know there are bacteria which is rapidly dividing and slowly growing. If we kill the rapidly dividing bacteria, the patient becomes non-infectious. To cure the patient, we need to kill the slow growing bacteria, and also we need to decrease the development of resistance. So before we understand this, we need to know how under what and all categories a patient can come. Patient is exposed to a TB bacilli, he develops tuberculosis, but we have to test him for drug resistance. If a patient is sensitive to rifampicin and isoniazid, those are the first line of therapy. If he is sensitive, we call him as drug sensitive TB. Similarly, we have multi-drug resistant TB. I'll explain it in the further slides what it means. Rifampicin resistant TB, where the bacilli is only resistant to rifampicin. Monoresistant TB, where the bacilli is resistant to one of the first line of drugs. Polydrug resistant TB, again one or two of the first line drugs other than isoniazid and rifampicin. We have the last category, extensive drug resistance TB, or also called as XDR TB. Multi-drug resistance TB is called MDR TB. How do we identify the tubercle bacilli is drug sensitive or MDR or XDR? For this we do testing. So we send the sample for CP0. We send it for CP0. In this we can analyze if the bacilli is rifampicin resistant, whether the patient is positive or negative in the given sample. Sample could be sputum, it could be pleural fluid, tissue from the intestine for extrapulmonary TB. After identifying if the bacilli is there, it can also identify if there is rifampicin resistance. To identify polydrug or extensive drug or even multi-drug resistant TB, we do line probe assays. It's cultured and after that the report is given. So, how a patient is going to be treated? Patient is going to be categorized into drug sensitive, multi-drug resistant or XDR. These are the minor categories which are involved. So, patient comes to us. First, let's try to learn about what happens if a patient is drug sensitive. Means he is not resistant to any of the drugs, any of the first line drugs. So we start him on a short course chemotherapy. So what are the categories in drug sensitive tuberculosis? We have only two categories. One is a new patient, second is a previously treated patient. So for a new patient, what is given? For a new patient, we have an intensive phase and a continuous phase. What is in intensive phase? We give 2 HRZE, that is 2 months of isoniazid, rifampicin, pyrazinamide and ethambutol. The later 4 months, we give HRE, isoniazid, rifampicin and ethambutol. This is a new patient. What does new patient mean? New patient means newly he has become sputum smear positive or a new sputum smear negative, but he has come as a positive case and a new extrapulmonary case. Means he has never been exposed to anti-tubercular drugs and he is drug sensitive. He is sensitive to all the first line of drugs. So we give intensive phase along with continuation phase, totally 6 months. In the first 2 months we give him 4 drugs. In the next 4 months we give him 3 drugs, HRE. We give him 3 drugs. This is for new patient who is drug sensitive. A previously treated patient, that is, who is drug sensitive but smear relapse case, a failure case or a smear positive after default. All of this will be giving 2 HRZES. Here you can see it includes streptomycin. Streptomycin for 2 months along with 1 month of HRZE. That is, intensive phase is of 3 months. In the first 2 months we give HRZE and streptomycin, whereas in the next month, in the third month, we give HRZE. So totally intensive phase for a drug sensitive TB patient, drug sensitive category 2 or previously treated patient, we are going to be giving 3 months of therapy. In the continuous phase, we are going to be giving it for 5 months. So the total treatment for previously treated, that is category 2, is going to be for 8 months. For a new case, it is going to be 6 months. For a previously treated, it is going to be 8 months. And these drugs have to be taken daily, every day. Every day these drugs have to be taken. Every day these drugs have to be taken. So what did we understand? We understood that drug sensitive TB can have two categories. Category 1, new patient. Category 2, previously treated patients. But both these categories are drug sensitive, means they are not resistant to any of the first line of drugs. So for the first category, category 1, new patient, you are going to be treating him for 6 months. Category 2, previously treated patients, we are going to be treating him for 8 months. So previously we used to get tablets. Separately, isoniazid, rifampicin, pyrazinamide, ethambutol. Now all of this comes in one single tablet as a fixed dose combination. All these drugs in one tablet. So each tablet contains isoniazid, rifampicin, pyrazinamide and ethambutol at these doses. That is isoniazid at 75 milligrams, rifampicin 150, pyrazinamide 1400 milligrams and ethambutol 275. So this is for HRZE. If we need HRE in the same, except for pyrazinamide, all the drugs are going to be there. This is going to be used for the intensive phase. This is going to be used for the continuous phase. Oral fixed dose combinations. These are given based on the weight of the patient. If a patient is weighing 30 kgs, he needs 2 tablets in the intensive phase and 2 tablets of HRE in the continuous phase per day. If a patient is weighing above 70 kgs, you will need 5 tablets per day in the intensive phase and 5 tablets per day in the continuous phase. So, if a patient is drug sensitive, there are going to be 2 categories. Category 1, new patient, you are going to be giving 2 months of HRZE and 4 months of HRE every day. If the patient belongs to category 2, previously treated, the total treatment is for 8 months, which is going to be HRZES for 2 months, HRZE for 1 month and HRE for 5 months. So total 8 months. How are the tablets available? They are available as fixed dose combinations. Each tablet will have isoniazid, rifampicin, ethambutol for the continuous phase, isoniazid, rifampicin, ethambutol and pyrazinamide for the intensive phase. So based on the body weight, these drugs are going to be given. So how fast a patient is going to respond to this treatment? Within 2 to 4 weeks, the rapidly dividing cells are eliminated. So the patient actually becomes non-infectious. And the slowly multiplying cells are killed and they are eliminated. Now, why do we need to combine so many drugs? If we combine, the risk of developing resistance, the chances of developing resistance is decreased and the duration of treatment also is decreased. That is why we tend to combine the drugs. Till now, we learned about drug-sensitive TB. Now let's go on to multi-drug resistant TB. Now what is multi-drug resistant TB? Multi-drug resistant TB is resistant to at least H and R. It is isoniazid and rifampicin. Resistance to isoniazid and rifampicin will be there. There could be resistant to other drugs also, but to categorize it, this is essential that it has to be resistant to isoniazid and rifampicin. If we don't treat this patient, the patient will die. Mortality is very high. So, what do we do in such a kind of patients? We are going to be giving him 5 to 6 drugs. 5 to 6 drugs. So, we have already learnt we have group 1, group 2, group 3, group 4 and group 5 drugs. So, from all the groups, we are going to be including 1 or 2 drugs along with pyridoxine. A simple regime approved by the RNTCP is for MDR TB. We are going to be using 6 to 9 months of intensive phase with kanamycin, levofloxacin, ethionamides, cycloserine, pyrazinamide, ethambutol plus pyridoxine. This is for the intensive phase. 4 to 5 drugs among this to which the patient is not resistant, we are going to be using. You can see isoniazid and rifampicin is not there because an MDR TB patient is resistant to both the drugs. Continuous phase, it's going to be for 18 months. We can use levofloxacin, ethionamide, cycloserine and ethambutol along with pyridoxine on both the phases. This is for MDR TB. If a patient is having XDR TB, also called as extensive drug resistance TB, where the patient is resistant to the 4 more effective bactericidal drugs, that is isoniazid, rifampicin, fluoroquinolones, and it could be kanamycin, injectable drugs. So in such a patient, we need to use the other line of drugs like capreomycin, moxifloxacin. You can also use high dose of isoniazid. Normally 300 milligrams is given per day. Here we can use up to 900 milligrams per day. PAS, paramannum salicylic acid, clofazimine and linezolid, amoxicillin with clavinate also can be used. Continuation phase is for 18 months. The same drugs are used for continuation phase. So at least 4 drugs it is resistant, so that is called XDR TB or extensively drug resistant TB. It is highly untreatable and mortality is very high, especially in patients who have TB plus HIV. We understood how to treat a patient with drug sensitive TB, multi-drug resistant TB and extensive drug resistant TB. Let's go to the minor things where if there is only resistance for rifampicin, then you exclude rifampicin in the treatment regime and keep INH and treat as MDR TB. So if it is rifampicin resistant, you treat as MDR TB with INH, no rifampicin. Mono drug resistant TB, resistant to first line other than rifampicin, then you will give rifampicin plus 2 drugs from the first line, that could be isoniazid or pyrazinamide, ethambutol, streptomycin, one streptomycin. From second line oral drugs, and one from fluoroquinolones. This is intensive phase for 3 to 6 months. We can also have polydrug resistant TB more than first line other than rifampicin. Only isoniazid resistance also can be there, isoniazid resistant TB. Here you can use a high dose of isoniazid. Instead of 300, we can use 900 milligrams if this resistance is because of INHE mutation. So, we learned today that under the RNA, we have drug sensitive TB, which is further categorized into category 1, new patient, category 2, previously treated patient. Multi-drug resistant TB and extensively drug resistant TB. How do you categorize in which group it belongs to? First, we send the sample, analyze it under CB0, whether the patient is positive or negative. If the patient is positive, we further analyze it for resistance to rifampicin. If we want to find the resistance to other anti-tubercular drugs, we use LPA. So, if a pregnant lady has got tuberculosis, we tend to avoid drugs like streptomycin. Ethambutol, we can give it in the late pregnancy. So, in the Indian regime, we tend to use 2-HRE plus 7-HR along with higher dose of pyridoxine. If a patient is breastfeeding and she's got tuberculosis, we're going to give 2 months of HRZE plus 4 months of HRE along with pyridoxine. And for the infant, you need to give isoniazid prophylaxis along with BCG vaccination. Chemoprophylaxis. Chemoprophylaxis is given to a person who has latent TB infection, latent tubercular infection, which can anytime develop into an active disease, like those who are exposed to the open contacts and they are showing the Montauk's conversion. Children with positive Montauk's and a TB patient in the family, neonate of a TB mother, that is the fetus, the infant newborn of the TB mother, immunocompromised patients who are showing Montauk's positive, just a HIV patient in whom the Montauk's is recently turned positive, HIV infected patients exposed to a sputum smear positive TB patient, a patient with old inactive patient with inadequate therapy in whom Montauk's is again positive. So we can go with isoniazid, which is a standard for 6 to 12 months. You can use rifampicin, alternative to rifampicin. If there is INH resistance, then you can use rifampicin for 6 months. If the patient is exposed to MDR TB, then we can use ethambutol, pyrazinamide plus or minus a fluoroquinolone. Corticosteroids are used in treatment of TB in certain cases where there is adrenal TB and there is adrenocortical insufficiency, or severely ill miliary TB or severe pulmonary TB, in hypersensitivity reactions to the drugs, antitubercular drugs. It's also used in patients where there is a viscera involved, like genitourinary, ocular, pericardial, pulmonary, pleural fibrosis, meningeal TB, renal TB. This prevents adhesion formations. Hence, because of the inflammation, there will be adhesion formations. So to prevent these adjacent formations, strictures, we are going to be using corticosteroids. But it is contraindicated in intestinal TB where it can cause perforation. For Mycobacterium avium complex infection, we have a intensive phase and a continuation phase treatment. In the intensive phase, we'll be using clarithromycin, azithromycin or azithromycin, ethambutol, rifabutin, plus or minus any of the levofloxacins. That is for 2 to 6 months. 2 to 6 months are decided based on the CD4 counts. For the continuation phase, we can use clarithromycin or azithromycin along with ethambutol, rifabutin plus 1 fluoroquinolone for 12 months. So usually what is the treatment guideline we use? Azithromycin 1200 milligrams in total in the week. Clarithromycin, rifabutin 3 months. For 3 months if the CD4 count is going down. This is for Mycobacterium complex infections. So we learned today TB. There is drug sensitive TB. In this you have 2 categories, Cat 1, Cat 2. This is a new patient, this is a previously exposed patient. In a new patient you have 6 months of treatment with HRZE for 2 months plus HRE for 4 months daily. For previously treated, you are going to give 2 months of HRZES plus 1 month of HRZE. This is intensive phase. In the continuous phase, you are going to give 5 months of HRE. This is for drug sensitive TB. For drug resistant, that is MDR TB, the treatment guidelines varies, where we are going to be using drugs other than isoniazid and rifampicin. The treatment guidelines can vary up to 2 years. Then we have XDR TB, where we are going to choose a drug from group 1, group 2, group 3, group 4 and group 5 and use in the treatment of XDR TB. Because this patient is drug resistant to 4 drugs including H and R, including isoniazid and rifampicin. We also understood that anti-TB drugs are classified as first line, second line, second line. These 2 are oral, fluoroquinolones and injectables. This is one way of classifying. The other way of classifying is as group 1, group 2, group 3, group 4 and group 5. Other than this, there is also Mycobacterium avium complex infection that is also treated and similar to that of TB, where there is an intensive phase and a continuous phase. And we basically use clarithromycin, azithromycin, rifabutin, ethambutol in the treatment effect. With this, we finished anti-tubercular drugs. Thank you.